This program is made possible by a grant from the Kugelman Foundation. This original WSRE presentation is made possible by viewers like you. Thank you.
Hi everyone, I'm Bill Harrell and welcome to Inside Healthcare. Our topic tonight is end-of-life decisions, advanced directives, mechanical ventilators, do not resuscitate, artificial hydration and nutrition, comfort care only. When it comes to these end-of-life issues, most people are confused, unprepared and frightened. However, decisions need to be made. Who should make these decisions and which quality of life factors should be considered? We'll discuss these questions tonight at this town hall meeting located at the Gene and Paul Amos Performance Studio on the campus of Pensacola Junior College. Stay with us as we explore the issues surrounding end-of-life decisions and what services are available in our area. Joining us tonight, we have a great panel of guests. With us tonight is Angela Bottesini, and she's the Director of Inpatient Facilities for Covenant Hospice. And welcome, Angela. Glad you could be with us.
Thank you, Bill. It's my pleasure.
Also joining us is Erin Bowers, and she's a palliative care manager at Sacred Heart Hospital. Welcome, Erin.
Hi, Bill.
And also with us is Dr. Donna Jacoby. She's a clinical associate professor at the FSU College of Medicine in Pensacola. And welcome, Dr. Jacoby.
Thanks.
Also with us is Dr. Dale Nee, and he's the president and CEO of Covenant Hospice. Welcome, Dr. Nee.
Thank you, B.
Also joining us is Reverend Jim Palmer, the Director of Pastoral Services at Baptist Hospital. Welcome.
Thank you.
And also with us is Jason Waddell. He's an attorney with Waddell, Brazil, PA. And welcome, Jason.
Thank you for having me.
Glad you could be with us. Well, Jason, I read a disturbing figure the other day, and this really kind of shocked me. They said of people 18 and over, only 30% had advance directives. Now, what exactly is an advance directive, and who can draw up one of these documents?
The advance directive is quite simply what your wish is should certain events happen. Depends on the circumstance. When we're talking about a healthcare surrogate, we're talking about if I'm incapacitated, who will make medical decisions for me? Whereas we get to living wills, we're talking more end-stage condition along with being incapacitated. That describes how you want to be treated, who's to make these medical decisions. And anyone over the age of 18 can make these decisions. And I think that has a lot to do with that study, is that people don't think they need them until they reach a certain age, and it's much, much older than 18. And I think that's a mistake.
We're going to talk a little bit more about that, some of the problems when people do not have advance directives. But, you know, we live in a society where we like self-determination. We like autonomy, right? We like to be able to decide what we want. But yet, 70% of the people, when it comes to end-of-life decisions, aren't thinking that way. Let's take a living will. What are some of the things that they have to think about when they're filling out a living will? What are just some of the issues that they have to address in a living will?
Really, a living will is a very straightforward document by and far. What they're trying to do is just decide what they want to happen should they ever reach that end-stage condition or persistent vegetative state, and they're incapacitated. It's their voice for them to decide, do I want life-prolonging procedures to be withheld or withdrawn, or do I want them given? It's very straightforward. It's not a complicated document for people to, I think they make it more.
Okay. Then we jump into durable power of attorney for health care. Now, maternity, and we don't want to get into that so far, but when we talk about attorney for health care, let's talk a little bit about that, because I think that's at the point when maybe something has not been laid out in the living will, and it's a little bit more complicated than just the elements of the living will. Explain that, please.
Well, with the way that it's impacted my office, or at least I've seen, is the healthcare surrogate or the durable power of attorney for healthcare typically comes up where there's something that's not necessarily end stage, that there could be, it lead to that, but we need to try something first. Who makes that medical decision? And so they are able to have that voice for you if you're not able to. And that's where we see the healthcare surrogate being played out most commonly.
Y'all, anytime you want to jump in, Dr. Jacoby?
I was going to comment, the living will can be very limited, but you're allowed to put specifics in those documents. And there's some published documents from different groups that help you work through different scenarios. One that's used a lot, I know, with Covenant is 5 Wishes. There's another called Project Grace, and it helps people think through what if. I think we as physicians love to have that living will, but to me it's much more important to have that healthcare surrogate, because there is no way you can put it all down on paper. You can't think through all the what ifs. So I want to be sure I have someone who can speak for my patient when they can't speak themselves. And it may be a very temporary need. They're confused from medication, they've been in an accident. Again, it's that young person out on the street or on the ball field who could get hurt and need someone to speak for. If they're young enough, it's their parents, but if they're independent adults, they've got problems too if they don't think about those things in advance.
From birth to 18, is it always the parents or guardian that makes the decision? Pretty much so?
I'll defer to Jason there.
Normally it's the natural guardians, which are the biological parents. If there's been some sort of custody dispute at some point where the children have been removed, then it could be the court-appointed guardian.
All right, so I'm sitting down and I'm going to do my durable power of attorney for health care. Who do I select? I mean, is that an issue? I mean, should it be my wife? Should it be my brother? Should it be a cousin? Should it be my son-in-law? Who should it be? I mean, do you see situations where, you know, it does put pressure on certain people to have to make very, very intense decisions? Erin, you're shaking your head.
It should be somebody that knows you very well. It should be someone that you've had a discussion with. When I am working with someone that's going to do an advance directive, I actually have them in the office. I bring the surrogate to be into the office with them so that they understand, and we go through scenarios. They have to understand each other's philosophy. And you know, it involves, there's intimacy, sometimes there's tears, because now we're talking about end of life. But I find that these are the best discussions to have. And then I actually send them away to talk about this, and they come back and make a second appointment with me. And those are the most successful that I see, because that person knows that person like this. It's not just putting a name on a piece of paper and putting it in a closet. It's that discussion that goes along with that document.
Well, that's interesting. Now, as far as the legal status of advance directives, if we draw one up in Florida, will it work in Arizona? I mean, what's the rules there?
It should. They should respect it as long as it was executed in the home state according to the laws of that state. It should be respected regardless. So if you're a Florida resident and you travel outside, your document should be valid. Same if somebody comes into Florida, you know, it's drafted.
And at that point, you know, trying to keep up with the actual documents themselves, let's say they're not available in Arizona. You know, what do those people know what to do and how to do it?
Well, I think this comes down to that communication of what to do when you draft them. Where do you put them? I see many of my clients wanting to share them with their children, and I think that's a great idea. I also encourage them to give them to their primary care physician and tell them to put it in that file. That way, if they're off rushing to the hospital, they're not going to be, thinking about where did I put these legal documents. They're going to the hospital. They're focused on their loved one. And when they get there and the question is asked, they can say, well, you can go to this person and they'll send it to you.
I know somebody's always said, well, I know it's locked up in a safety deposit box. I mean, y'all ever heard that one? And a lot of people have done that.
Bill, the other thing you can do too is I tell people, you know, in this day of technology, you can scan the document and put it on a PDF file. Some people carry it around with on the stick, so it's transportable.
Now, Dr. Jacoby, there's much discussion about some new document, and it's called Physician-Ordered Life-Sustaining Treatment, or POLST? POLST, okay.
Right.
And what does this legal medical document do? Why is it different from an advance directive or living will or the power of attorney? How is it different?
POLST is not yet approved in the state of Florida, but there are a number of us around the state hoping that it becomes another option, like the DNRO that does exist, that's a form that has to be on yellow paper, that is a physician's order that says this person is terminal or end stage, and should they have an event where they need resuscitation, that resuscitation would be withheld. And so that form gets posted above the bed if you're at home. It goes with you from nursing home to ER, gets used at the hospital. But a lot of us, I think, worry when we get to talking about end of life, it's that people are taking everything away from us. They're withholding things. But I know from caring for people at end of life, sometimes it's very aggressive care to help them make the most of the time they have left, to be comfortable. And what Pulse does is provide orders that specify what your condition is and then what treatment you would like. So you can make it your own with your doctor. Do you want IVs? Do you want feeding? Do you want antibiotics or not? Pain control, comfort care is an automatic part of the document. But it's meant for people not just at death's door, but people who have chronic conditions who want to have a voice in how they're taken care of. And rather than it being a document you have to find buried in a chart, it's an order with a doctor's name attached that can move with you, just like that do not resuscitate order that we have right now.
Is it fair to say that there's more physician involvement in creating this document than maybe some advanced directives?
It's got to have a discussion. The doctor has to document what the patient's condition is. So the person at the other end can also check and kind of say, yes, this fits, this is what I'm seeing. What we talked about in drafting it for Florida was that the patient would also co-sign that. So it would help avoid that issue of someone drafting it just based on their opinion or on a family's opinion. It needs to be reviewed with the patient. It's also not meant to be something that never changes. As your condition changes, you change that document. You can always, any of these documents, void them by just tearing them up, signing them. They're not things that you're bound to if you change your mind.
Wanted to shift gears a little here and talk about caregivers. And you know, when we talk about end of life, there's usually somebody that's taking care of someone. And how does this intense situation usually affect the caregiver? You know, some of the figures are startling as far as you know, a caregiver actually getting sick, him or herself. They're usually a little bit older in age. You know, they're taking care of their spouse. There's just all sorts of things that can lead to poor health as a result of trying to take care of someone. What in your experience have you seen, and what should people try to do?
Well, I think most of us wish that we'd have a sudden illness and death, but the majority of deaths in our country don't happen that way, and it usually is a chronic condition. I think current estimates are about 2 out of 3 of us are going to need long-term care support. And we all think that's going to be our family, our friends, but oftentimes families around the country elsewhere, or there is no family, or as you said, it's a real frail little wife taking care of an ill husband. The things that are supposed to be of benefit in extending the life of the caregiver are things like just recognizing that they are a caregiver and giving them emotional support. Respite care, where you give that person a break. For some of the folks with Alzheimer's, for example, it's not even the caregiver leaving the home, but they've got time to go take a bath and rest without their loved one coming in and hovering over them. But just a few hours a week can make a huge difference in how much they can tolerate. Education that's very specific. How do I deal with bathing or wandering or losing control of bowel and bladder? Those kinds of things help. And then support groups. Our community's very lucky because we have a number that are for Alzheimer's, Parkinson's disease. Council on Aging sponsors some that are for caregivers in general, because about 40% of the long-term care are younger people. They're not the senior citizens. And so we do have a lot of resources if you feel like you can get yourself there. Most caregivers are so busy they won't take the time to go. But I tried to encourage my patients' families, if you could just go once, make some connections, find somebody you can call on the phone. These days they're internet support groups, but somebody else who's lived through it too is able to share their experiences can just make a huge difference.
I know you've been on the board with the Council on Aging of West Florida, and they have a fairly unique program. It's kind of like taking, you know, the idea of daycare for children and applying it to adults. It's called the Adult Day Healthcare Center, and it's located in Pensacola, and it's a service that they have. And we recently talked with the director, Sandy Holtree, and we're going to roll a videotape now and let people really take a look at what this center is all about and how it can help the caregiver get a little bit of that rest that they need.
The Adult Day Healthcare Center in Pensacola is the only licensed center of its kind in the Panhandle of Florida. It provides a protective, stimulating environment for adults with cognitive and physical problems.
Our adult daycare center is a home away from home. It's full of fun and friendship. It's a safe, secure environment for seniors over the age of 60 with cognitive impairments such as Alzheimer's disease or some type of dementia. And that's a large percentage of the clients that we serve. But we also have clients who have physical impairments, a history of a stroke, fractured hip, diabetics, heart disease, and so the nurses can monitor them and assess them. And we have served families in Gulf Breeze, Milton, Lillian, Robertsdale, so we see families from all around the area coming to Pensacola to use our adult daycare center.
The center also provides much-needed respite for the people taking care of these older adults.
We see a lot of children that are taking care of parents. Those children still have their own children to raise. They may possibly work themselves, so they drop off mom or dad in the morning, they go do their 8 hours of work, come back, pick up mom or dad, and then take them home. So we are preventing long-term care placement. When the caregiver brings the family member to daycare, it is a safe, supervised environment that gives the caregiver time to go to those doctor's appointments, to take care of themselves. What we see with the older married couple, the spouse is very hesitant to leave the family member at daycare. The client has been so dependent on the spouse, usually a wife, and she's small, she's frail, she has medical problems herself, she's tired, and she just needs a break.
A service of the Council on Aging of West Florida, the center maintains a staff-to-participant ratio in accordance with the state of Florida licensing requirements.
The ratio is 1 staff member for every 6 clients is the minimum. We have 2 LPNs that are on staff. Myself, I'm an RN, so usually there's at least 2 of us here, a lot of times 3 nurses, and then we have 4 nursing assistants during the day.
The 2,500 square foot center is designed for indoor and outdoor activities in a variety of settings. Positive outcomes are achieved for the participants.
Generally, we see clients begin at 1 to 2 days a week of attendance, and then they gradually, as they trust the staff, as they get used to the routine, attending daycare, then they increase their days. 5 days a week generally is great for the clients. That is a daily routine. We see that with Alzheimer's clients, dementia-type clients. The structured routine, the same daily routine, is much better for their behavior. I believe coming to adult daycare gives the clients a purpose. We hear from families that the clients sleep better at night because they're awake all day. We do an annual survey every summer to the families, all the clients that participate, and we just hear all those positive remarks. Mama sings in church now. Mama wants to wash the dishes at home. Daddy reads the newspaper now. He hasn't been interested in that for a long time. So we just hear these positive remarks in our survey from the families, and then we see it in the clients.
A physician's order form must be completed prior to enrollment.
And there is a simple form that the physician completes. It lists their diagnosis, their allergies, their diet, medications, and the state is interested to make sure they don't have communicable disease, infection control. So they either have to have a chest x-ray or a TB skin test prior to admission. We also have services available for physical therapy, occupational therapy, and speech therapy that a physician can order on that form if he thinks the client would benefit.
The center is open from Monday through Friday from 7:30 a.m. until 5:30 p.m.
The center is $65 a day. The number of days that they attend is totally up to the family. It could be 1 day a week, it could be 5 days a week, or sometimes it's just PRN as needed just a few times during the month. It's very reasonable. If you hired someone to come in your home, one-on-one, a private sitter, I believe you would pay much more than $65 for, say, if you used 8 hours. Plus the benefit here is there's other clients here, they're with their peers, there's much stimulation, socialization, activities going on, there's singing, there's dancing, there's always something stimulating. Anyone that's interested in daycare, if you're a caregiver, come by, tour, see our facility, see the fun that we have. We'll be happy to take care of your client.
Dr. Jacoby, a wonderful service of the Council on Aging of West Florida, providing that center. We want to take some questions from the floor, and this first one, they did not write their name down, but it had a little bit to do with what you were talking about, and that is how do you shape the conversation about trying to get people to decide, you know, what they want to do as far as end-of-life decisions and all that. And when we were looking at the healthcare reform debate, there came up this thing about death panels, and it got to be a real, you know, incisive, you know, I mean, just it was inflammatory, you know, and all that. And really what it was they were trying to help pay physicians money to be able to sit down with their patients and talk about end-of-life decisions. Is that right? What was this whole thing about death panels all about?
As a geriatrician, we'd been trying to get that type of a code in the billing system for years and years. So we were excited that it was a part of healthcare reform. And the death panels were just a scare tactic, and it was such a shame that it got removed because of that. But I think as physicians, most of us had very little training on how to have those conversations. I know I scared people to death. You know, I would go in and say, now if your heart stops, do you want us to try to start it back? And that's not the right way to go about it. They stayed awake all night in the hospital to see if they were going to live through the night. But I have learned over time, and I've learned through working with the medical students and some great support through the hospice and palliative care folks here in town, that there are ways to have those conversations, but they take time. They take a patient trusting you to have those conversations. And so that attempt to reimburse for the time was to hopefully encourage physicians to take the time to do that and to build their skills. One thing I found that was helpful for me was a physician who helped you shape what the patient's health status was, whether it's you and me, fully healthy, independent in all ways, to the person who's at death's door and everything in between. But then to have a conversation about how do you stack up your goals, life, function, and comfort. And if I could get people to think through those 3 things, not 10, 15 goals, but how would you stack those up? Then you could help to shape what their plan of care should be. And not just do you have a living will, do you want resuscitation, but my own mother has Alzheimer's, and our goal for her right now is to keep her functioning as long as we can. So our wish is if she gets sick, we want her cared for where she's living now with the people who know her, know how she likes to be treated, knows how she likes to have her food, and not ship her back to the emergency room and the hospital and ICU, because that would be so traumatic for her. But it takes someone who's willing to help you think those things through, talk about them, give you time, as Aaron said, to talk with your family and those healthcare surrogates, and to put a plan together that's not aimed at a crisis, but at a logical way of how you want to be cared for in the future.
And sometimes that time is just not there in the hustle and bustle.
And part of it's because we just don't think about it.
Okay.
You know,
Well,
how do you
have
that in your mind?
We have a question from Ann Bennett, and this is really an issue involving something that you might put in your living will. It has to do with artificial hydration. And Ann, why don't you talk a little bit about your concerns with artificial hydration?
Well, I'm not sure that I really understand all that it is, but you know, we were trying to fill these things in with an attorney, and we got to this part, and we just hit a wall. So I'm sitting here saying, if you give a person water, how much trade-off are you looking at between the patient's comfort and prolonging the suffering or the dying. Am I making sense?
Mm-hmm. Yes, you are.
Thank you.
Yeah, we've got three people I can see shaking their heads. They're ready to. Angela?
And what I'd like to tell you, and what we talk to our hospice patients and families about, is absolutely the patient is the guide. And when a patient's body no longer can metabolize the fluids or the food that we normally put in our body, that's a time you start looking at making decisions otherwise. When bringing those fluids in or the hydration in causes the lungs to fill with fluid or the abdomen to distend, that becomes a comfort or a benefit versus the burden. So we ask them to begin to look. There will come a time when your body metabolizes things a little differently. It will need all its energy to help your lungs work efficiently. It will have, the energy will need to go to your brain to work more efficiently. It won't need that to feed the body. So what happens is the fluid goes in, then you begin to get distended or build up fluid in the lungs and you're uncomfortable. That's a point when most people don't want to continue to do that. It's doing harm, not good. Does that help at all in answering your question?
That just raised a whole new.
These conversations are very long.
And Ann, let me just tell you that the person is going to take food and water as long as they want that. Mm-hmm. You know, the natural way is obviously to take that through our mouth. But when we start to force feed someone at the end of life, that fluid can come back up and it really can cause some distress. The most comfortable patients that I take care of, and I take care of thousands, and so does hospice, are those patients that are not filled with fluid. They've actually done studies, okay? In our bodies, if you can think of a time, you know, when you've been so sick that just the smell of food or water, you don't want that. You're pushing it away. And you'll see patients actually do that many times in a semi-comatose. They're pushing their family, and their family's trying to, you know, feed them, and they don't want that. It's hard for families, so we sit down and we do a lot of talking about this. But you'll find that patient, that are the ones that are the most comfortable, are not filled with all that fluid. The body actually releases a chemical very much like morphine internally inside of itself at the end of life that really comforts the body during that time.
Well, Ann, thank you so much for that question. We do appreciate that. And Aaron, we want to jump into palliative care. You manage the area over at Sacred Heart. Just a quick definition of palliative care. How would you define it?
Palliative care in the hospital setting is that our focus is on symptom management. We work with patients and families to help them with pain issues, shortness of breath, everything that comes along with illness, chronic illness, serious illness, but actually can be delivered at any time during the process of any kind of disease. So they don't have to, you know, there's this hole or this gap sometimes in healthcare where we say, you know, before the patient really is going to go to hospice care, is that we are able to help them through a lot of this transitional period and to help with symptom management and to help with some of this transition.
Now, as far as early on in the disease process, you'll be able to help them with pain management and things like that. I guess first thing when you think palliative, you think about, you know, going away from curative and into palliative. So you're still in the curative state, but controlling comfort, right?
We can see patients at any time in their disease process. Sometimes I see patients, you know, for 2 or 3 years. And as their disease process progresses, we're talking and having more and more discussions about just what Dr. Jacoby was saying about their goals, because their goals are starting to change through this whole process.
I wanted to just kind of for the whole panel, I don't know, Jason, if you've ever been involved in this, you may late at night, but when we're looking at making your intentions being known, that means, you know, somebody knows, you know, what you want, you know, when you're declining and that type of thing. You know, what are some of the situations that come up in the hospital setting that could have been avoided? And I know, Aaron, you probably deal with that every day, and you deal with families. It can be very, very difficult situations with families, especially when you have siblings fighting each other and you have, you know, maybe the father, you know, what goes on in the hospital setting when these decisions haven't been made, when people just don't know?
I think probably one of our biggest problems in our country and with healthcare is the communication issue that happens. Because, you know, in our hospital settings, everything is very fast-paced, treatment-oriented, and many times, just like we've been talking, is that we haven't had these discussions. So some of the biggest things that I see are in the intensive care unit, people on life support, ventilators, dialysis, all of this medical technology that we have, that we may be doing a lot of things to the patient, but are we doing them for that person? So we have to stop and sit down, get everybody together, the physicians, the family, to really talk about what is the goal of care here. And unfortunately, sometimes this happens in a crisis situation just because of the very thing that we're talking about today, is because nobody wants to talk about it.
We had another question from one of our studio audience members. They didn't want to talk, but I'll read it and see what you think. If a comatose or mentally incompetent patient doesn't have a living will or some type of attorney to help decide, that's not right. It's really somebody else, right? Who decides whether to withdraw treatment? In other words, how do you get into a situation like that where you don't know, but at some point, you know, there's futility involved, they're not going to get better? Who makes that determination?
I'm pointing to our ethics expert.
All right. Well, Reverend Palmer, do you want to start in on that?
Well, and it's listed in the Florida statute 765 about advance directives. If there's not an advance directive, designation of a healthcare surrogate or a durable power of attorney for healthcare, there's a proxy. It goes to what they call the proxy decision maker, and there's a hierarchy where the phrase many people use is next of kin. And that's not really the legal term, but it goes from the, like in a court-appointed guardian to a spouse to the child or a majority of adult children to siblings and on down that way. And those are the people who would be the ones who would be making decisions.
So there is a, you know, something to guide people through the process.
Correct.
And I wanted to go back to you, Reverend Palmer, about hospitals having medical ethics committees. Tell us a little bit about that. Why do y'all have those?
Well, part of the reason for ethics is the struggle of trying to find what is the right thing to do for the patient is what's been talked about here. What's the good thing to do? And as we see that is, what does the patient want? You know, again, were we doing things for the patient versus doing things to the patient? And some of the same things that we get involved in often are issues that are related to lack of communication. One of the things that has happened over time is you no longer have your physician that you've known for most of your life, that knows you, that knows, you know, what you want, what you don't want.
Don't hospitals now have internists?
Or hospitalists, right?
Hospitalists, I mean,
or something? You'll come in and see a physician that you've never met before. So it's all that more reason that it's important to put down your wishes or to designate someone to be your decision maker, a healthcare surrogate. But sometimes we get called in when there's that question about, well, who is the decision maker? There is no paperwork, so how do we go through this hierarchy of determining who's making the right decision? Sometimes we get called in because there's disagreement either between family members or between family members and the medical staff about what should we do and what do we not do.
So can it get pretty
it can get pretty
dicey?
complicated,
Yeah.
yes.
Now, who serves on the committee? I mean, who are the people that are making these decisions?
Well, the ethics committee works to bring all the information together and try to piece this together and make a recommendation. The committee doesn't actually make decisions, but they make recommendations for the healthcare staff about what needs to proceed or what we would think would be the best. We have nurses on the staff, we have some community folks on our staff, we have physicians on the committee that all work together and meet regularly to kind of talk about, we do educational things about educating about ethics issues, and also keeping current on what the latest is in the law about what the law has to say about these things.
So what would be some of the things you deal with? Would it be dealing with infants? Would it be dealing with people that have been involved in automobile? I mean, what kind of situations do you have to deal with?
By and large, most of ours are end-of-life issues. Usually, as was mentioned before, chronic, long-term illness and issues. Occasionally, terminal situation following an accident or an injury of some type. Our committee, we don't have many infant cases. Most of those all go over to Sacred, to the Women and Children's Hospital. But again, it's dealing with those issues of how do you find the right thing to do, and what's the best thing that this patient, and what does the patient want? Because that really is what it all comes back to, is what does the patient want to have done?
Right, but you don't
If you
always
don't
have
have
a
it,
document that,
then you
and
have
that's
to-
kind of the theme of the show tonight,
Right.
that they haven't, 70% haven't, you know, let people know what their intentions.
And that's why I think this is important to do events like this, to get people to fill out an advance directive, to name a healthcare surrogate who can speak for you. One of the things that we face all the time, we get a lot of patients come from nursing homes and they don't have an advance directive. And it's like, that shouldn't happen.
Right. And they even said in nursing homes, only about 50% you know, have advance directives. So, and wasn't in Aaron, 1990, wasn't there a law passed that when you go into a facility, they need to ask if you have an advance directive?
Well, that's the Patient Self-Determination Act that came out in 1990 about that we should all be doing advance directives. So, but
so
many times
here we
when
are, what, 20 years later, and we're not making much headway, are we, Dale?
None at all.
The
None at
law
all.
is
I
you
think
have to ask,
Yeah.
not
Yeah.
that you have to
not
do
that you do have to do it.
Yeah, you have to ask. Okay,
you have to
so-
ask.
Bill, you know, one of the things too we found very important with Covenant Hospice is that if you have the advance directives telling everybody in your family what you want, so that they all hear it, because at a time when you're facing a crisis, that's when the triangulation comes in. But they all need to hear from your mouth to their ear what your decisions are.
Well, we've got a couple here that we were handing out 5 wishes, and then there's one called Advanced Care Plan document by Project Grace. So I mean, they're basically fill in the blanks. I hate to use that term, but they're not complicated legal documents, right, Jason?
That's correct. They're not, and there's something that people can readily get. It's not an expense. I mean, I think a problem that we see is a lot of people are trying to bring attorneys into it, and they think, oh, it's an attorney, so it's going to be expensive. That's not. It's not the case here, and you can talk to your physicians, you can talk to Covenant. These documents are readily available for free, by and for.
Well, before I leave this, Reverend Palmer, I want to talk about an ethics consult. Now, you know, I understand a medical consult when a doctor meets another doctor and they say, we got a patient, but what are they asking y'all to do in a medical consult?
Well, for the ethics consult, often it's those situations where there is a disagreement, and how they need a third party, someone to come in to kind of help bring all the players together to communicate, and often it is an issue of miscommunication. But trying to bring everyone together to try to determine, again, what's the best thing for this patient? What does the patient want? Oftentimes it is like, you know, siblings don't agree, or the disagreement between the family and the medical staff. So how can we work with these folks to determine, you know, what does the patient want, and how can we get everybody on board to the same plan?
I've got another question here from an audience member. They're not going to ask it in person, but theirs really deal with, you know, the final you know, 6 months of someone's life and how much is actually spent, you know, maybe sometime in critical care units, intensive units, and that type of thing. And maybe some of them don't need to be there. You know, from y'all's perspective, I'll ask, you know, everybody on the panel here, you know, are we spending a lot of money, usually with Medicare patients, treating them, and, you know, they don't get better? It's basically a futility, but families or whatever are asking, you know, everything you can give. Anybody have any comments on that, you know, or? Okay.
Yeah,
Aaron?
Yeah, absolutely. I mean, there's been many, many studies, and it's just millions and millions of dollars that are spent in those final 6 months of life. I think, to me, though, the human element is so gut-wrenching. You know, our intensive care units were never intended for, you know, the elderly patient, and I'm just being fictitious here, with the patient that's 95 years old, that's on a breathing machine, a ventilator, and their arms are restrained to the bed. And I mean, it was never intended for that way. And it's very difficult to watch someone die in that manner, that could be home with their family, home with hospice support in their own setting with family around. You know, we used to be born in our homes and we used to die in our homes. And then everything started to change and we started dying in hospitals with all this technology, and which is a wonderful thing, you know, for when it's appropriate. But when it's not appropriate, it can be very distressing to watch somebody die in that setting. It's not intimate, it's not close. It's much better to be in a setting that is in the home setting or in the hospice residence, somewhere where the family can be close together and be intimate and not have all this machinery around them.
All right, Dr. Nee, perfect transition into something you've been involved in for many years, and that's the evolution of the hospice movement. Just briefly, what is hospice?
Sure, Bill. Thank you. Hospice is really both a philosophy of caring for people reaching into their lives, and also has its very practical aspects. So from the philosophical standpoint, it focuses itself on quality of life, not necessarily length of life. So the emphasis is very heavy on quality of care for the terminally ill. And in doing that, we recognize in hospice care that given the opportunity, the great majority of Americans, approaching 90%, would prefer to spend the last 6 months to a year of their life in their own home or in a private residential setting. And so hospice does emphasize care in the home, even though we have our own facilities and we certainly take care of patients jointly in the hospitals with the hospital staff. So the philosophy has its foundation in quality of life. From the practical standpoint, the way we approach that is through a multidisciplinary approach, not looking just at a patient's physical needs, but also looking at their psychosocial and their spiritual care, with the idea of being able to bring a multidisciplinary staff to bear in taking care of all those issues. We realize that there can be many kinds of pain. There can be physical pain, spiritual pain, psychosocial pain. And in order to relieve that pain and provide comfort care, palliative care, we address that from a multitude of directions. Also unique to hospice is the bereavement care, because we also know that one of the pains a patient may be experiencing is worrying about what's going to happen to their family once the patient is gone. And so we're able to assure them that hospice is going to be with them, with the family, even though the patient may be dead. And we do that through our bereavement programs.
I want to make sure people know who's eligible for hospice services, and at what point do they cross over, I guess, and are eligible for hospice?
Yeah. Basically, anyone as far as age and disease is eligible for hospice. Unfortunately, we have over 70 children right now, and we have a lady over in Alabama that's 101. And so, and all of the diseases, everything from cancer to Alzheimer's and so on and so forth. In Florida and in Alabama, where we Covenant operates, we can admit a patient with a prognosis up to 1 year. Normally, our patients have a prognosis of less than 6 months. And on average, unfortunately, the patients are with us normally less than 2 months.
Now Donna, is that doctor sitting down and saying that this patient is terminal? Is there something that has to happen from a physician standpoint?
I think we have, as physicians, the same problem in having those discussions. It's when to think about hospice, and too often we wait till people are too desperate. And so it's making yourself stop and think, if this person follows the natural course of their disease, do you expect that they'll still be here in 6 months to a year? And if you think that that's possibly the answer is no, they won't, then you can make the referral to hospice, and their team, including the physicians they have on staff, will look at the situation and help make the decision. My first non-cancer patient I sent to hospice lived over a year. He had congestive heart failure. He was in and out of the hospital every week. I used every specialist I could find at the hospital, and we just couldn't get him stable. But the staff was so supportive of the wife. When he got in trouble, they called them, and they helped her work through things at home. I made a couple of home visits in a year's time. He never even went to the emergency room, and I was just amazed. So you're not penalized if you guess wrong, and people do come off of hospice, and then when their condition deteriorates, they go back to hospice. But it's just a wonderful resource because it doesn't support just the patient, it supports that whole family.
Now, when we think of hospice, we think of care that's delivered in the home. But in Pensacola, we have 2 inpatient facilities, and we had a chance to visit those facilities and talk to Angela. You showed us around. So let's roll those tapes and look at really something that's fairly unique, having 2 inpatient facilities in a town our size.
When a life-limiting illness is no longer manageable at home, inpatient facilities can provide comfort and support to patients and loved ones. There are 2 facilities located in the Pensacola area: the Joyce Goldenberg Hospice Inpatient Residence and the Covenant Hospice Inpatient and Palliative Care Center at West Florida Hospital.
Probably about 75% of our patients come from our patients in the homes that we care for. They come into our Joyce Goldenberg residence. And those are people that find themselves in a crisis, unable to care for themselves, or that their caregiver can no longer care for themselves at home. It could be an acute onset of respiratory distress or pain, anxiety, bleeding. Those patients come here. Then on the other hand, we have many patients that come directly from the hospitals within our area. And then outside of our area, we have people coming from Birmingham and Texas, Louisiana. And they're usually, for instance, coming out of the hospital in a surgical situation, and they've just discovered a pretty profound illness that limits their life expectancy. We have 24-hour-a-day care. We do all of the activities of daily living for these patients. We make sure that they're clean, that they're bathed, that their hair is washed. We do manicures, we do pedicures, we do massages. We do many external things that are in a holistic way of thinking and under hospice care. Over the years, it's evolved. People come to physicians now much, much sicker. There's much more going on. There's much more life-sustaining things. So when they finally make a hospice decision, our average length of stay is 7 days. So that tells you we get patients that come here for an hour and then may stay here 2 or 3 weeks. So a lot of times they are critically ill, and the doctors have continued to do a lot of treatment. By the time we get them, our stay may be very, very short.
The Goldenberg Inpatient Residence is a well-equipped facility with 16 private rooms in a tranquil setting. It offers a full continuum of specialized care 24 hours a day. The atmosphere is home-like, and visiting hours are unlimited.
We have a pharmacy here at both of our units with big guns, and we have a physician on what we call a 2-call ring. So within 2 phone rings, we have a physician on the other end of the phone helping us make orders so that we can immediately get patients comfortable, situated, calmed down. One of the things here that's very special is we have a cook. So when you walk in, you're smelling brownies and pasta cooking and fried fish on Fridays, and it's a different environment. We have the beautiful Japanese garden, memorial garden in the back.
The 9,000 square foot center at West Florida Hospital is located on the 3rd floor and offers 16 beds. It is fully staffed by Covenant Hospice in a pleasant environment that allows the patients to be surrounded by loved ones. A family member or loved one is welcome to remain overnight with the patient. Anyone, including children, can visit anytime.
Every single room at both units are set up so that the family can stay at the bedside. We have beautiful sofas that pull out into king and queen size beds. And we have washers and dryers in both of our facilities, and we just, they can move in and be right here at the bedside. West Florida Care Center that Covenant Hospice put in 5 years ago, we leased that space from the hospital. And it is a beautiful environment. When you come through these glass etched doors, the lighting is totally different. You're enveloped into a chenille blanket of care and love and peace in that environment as well. You don't even know that you're in a hospital setting. Primarily, most of our patients from West Florida Hospital and other hospitals come there, many of them out of the ICUs, and we can manage that care.
The concept of care at inpatient facilities supports the belief that everyone has the right to die pain-free and with dignity, and that loved ones will receive the necessary support to allow the patient to do so.
Normally when a patient comes through the door, the caregivers are exhausted. They're exhausted mentally, physically, spiritually. So what we tell them and what we do is we give them an opportunity to rest. If you need to go home and be with your animals or your young children, they know by what they see that their loved one is safe and secure and in good hands here, and they're able to go away and go spend a night at home. And then every day that they are here, our social workers and our chaplains and our nurses and physicians meet with them, and we kind of follow their guide. They take us where we need to go. If it's answer tough questions, and we let them guide us what they want to know and how. May be the first time that we can say to them, we've got it. I would like to invite anybody in this community that can see or understand what we're doing to come here 24/7 and tour our facility and just see what you have at your fingertips, so when the time comes that you have to make decisions, at least you know all the pieces to the puzzle and you know what we have with Covenant Hospice in these 2 units.
Angela, we appreciate you taking us on a tour of the 2 facilities, and had a couple of questions here about, you know, once someone is admitted to an inpatient hospice care, will the person still be able to see some type of treatment, or is treatment options pretty much gone by then?
Absolutely. Treatment is based on the patient's need. Now, they've pretty much given up by that time aggressive treatment, but treatment comes in a lot of forms. It could be palliative radiation, for instance. Could be hydration fluids. There are many different treatments, and we treat a patient so that their comfort level is met. So basically, yes, we can do what's needed to be done.
So can a patient's condition actually improve?
We have graduates all the time from Covenant Hospice, and it can. A lot of times patients come to us extreme pain, anxiety, spiritual and physical, and once you get those things under control and those needs met, a patient begins to live again, and that's our goal. Come to us, let us get those symptoms under control, and then go take your world cruise or Mediterranean cruise or trip. So it's about living, Bill. It's not just about dying.
Well, that's great. I wanted to, I had a couple of questions here, and one was actually about paying for hospice, and Nigel Allen is with us, and Nigel, you can ask a question, but I think, is it any different from any other healthcare payment? Or you can ask the question.
Well, I think a question a lot of people have is simply with all of the kinds of care that can be delivered through hospice care, there are probably different levels of cost. Can you talk a little bit about how hospice care is reimbursed? Is it an insurance benefit? Is it something that everybody is entitled to? How do these forms of treatment and care get provided to patients and family members?
Real short answer is that we are reimbursed primarily by Medicare. Most of our patients are Medicare eligible. Certainly TRICARE here in this area, major reimbursement. Most commercial insurance companies have a hospice benefit. I think the most important thing is, as a Medicare provider, and certainly Covenant Hospice will take patients regardless of their ability to pay. We like to say it's the last question we ask when we're getting a referral from a physician and admitting a patient. So it is a comprehensive way of caring. We do have some patients that have private pay. Last year, for example, we provided about $2 million in indigent care, and so it's a significant benefit.
Wanted to move on to something, Dr. Nee, that I think is very important. You serve as a national director for the board of the National Hospice and Palliative Care Organization.
It's a mouthful.
So that's the big board, right?
Yes.
Okay. And in this healthcare reform legislation that was signed into law in March, there's some concern about hospice payments in the future. Can you tell us, like, at about the $30,000? I mean, really, when you look at what's going to happen to Covenant Hospice when it comes to trying to reduce Medicare costs. It's Medicare costs, right?
Yes, Medicare.
Okay.
Yes,
Right.
yes. I firmly believe Covenant is going to be in very good shape in terms of our stability. My fear is, in particular as a national director, the smaller hospices that do not have the volume we have and the infrastructure are going to be in trouble, and they're already in trouble. We in hospice were very disappointed in healthcare reform. It certainly did not address a lot of the things that we hoped would be addressed, some of which were talked about tonight. There are reimbursement cuts, potentially up to 16% over the next 10 years. So all in all, when we feel the emphasis should have been on the cost-saving aspects of hospice and palliative care at the end of life, that was not in the healthcare reform package. Hopefully,
yeah. Does hospice save money for Medicare? I mean, from what we've talked about,
yes.
if expensive hospitalization versus
yes.
hospice, you'd think that.
The last major study that was done was 2 years ago by Brown University, and they estimated for every dollar spent in hospice, we save Medicare $1.50. And so there is significant savings. However, that did not appear to be recognized.
Well, all right, we're at the end of the show here, and I wanted to make sure if anybody had any closing comments. We've got about 2 minutes left. Anything that we didn't cover that y'all really feel like when it comes to end-of-life decisions that people just aren't aware of? Donna.
There's one area that I think we want to at least mention, and that is preparing as best you can to support yourself in end of life, not counting on Medicare to do it. They're not going to cover your nursing home. It's private pay if you need assisted living. For most of us, it's private pay help at home. The state has some programs, but they're long waiting lists. And so things like long-term care insurance, something to be on the lookout in the health care reform to see how the details work, is called the Class Act, where any of us that work, even part-time, can pay in and then receive on the other end, regardless of your age, regardless of your disabilities. It won't be to support everything, but it'll be a good help if and when you need it. I'd add that.
All right, 1 minute left, and I've got to ask this question. Came from the floor. Do you envision legalization of physician-assisted termination of life? Will that ever happen, Dale?
I believe that in most states eventually it will. And the reasons for that is that there are every indications with the aging population and some other aspects that having that choice is something that's becoming more preferred. And certainly we already have 2 states where that has been legalized. I certainly think in Florida we're looking at quite a few years from now, but there are other states that appear to be moving in that direction, including California and a few in the Northeast. So eventually I believe in this country we'll see that.
Well, I want to thank y'all so much for coming out tonight and being with us. We do appreciate you being part of this Inside Healthcare Town Hall meeting on end-of-life decisions. And thank you so much for watching this program. And we'll see you next time on Inside Healthcare. If you'd like to visit the website, it's wsre.org/health. And please go there, and we've got some additional information. Thank you so much, and we'll see you next time.